different kind of muscle tears, etc. Strains is the word I was looking for. But if it's done properly, there's the hinge at the hip, there's the tension in the calves because this is being flexed here, not just at the hips. And then once you find that point of tension, that's when they go down for a deadlift, and then they're here. All that tension is here in the posterior chain, which supports the back. So if you look at elite athletes, elite deadlifters, a lot of them actually have what is commonly viewed as very bad form because they have kyphosis in their back. They come here and they're a bit rounded and they're lifting this super heavy weight like this. How are they able to do that without hurting themselves? Elite athletes obviously can't afford to be out of commission. So the point, they're so well trained in developing the tension in their posterior chain that they can afford to get a little bit of kyphosis. And they want that kyphosis because in the competitive sport of deadlifting, it decreases the range and does put you into a little bit more contracted, tighter position. But the key is that you have to establish that force and that tensegrity, that tension prior to the movement, and then there can't be any movement at the spine. So if they're coming down for that deadlift and they're starting here and they felt where they're tight and they know that the power is engaged here and they have that tension, that's okay. However, if they were to lift and the spine moved as they're lifting that heavy weight, that can get dangerous really fast. So you're playing with fire, you know. But if you do it right, it works out incredibly well. But you definitely don't want to do it wrong. The other thing with the feet specifically and the hands, your two appendages here, is they're very innervated. They have a ton of nerves. So everything that the foot does dictates what the knee does, it dictates what the hip does, and therefore dictates what the back and the rib cage does. With the hand, everything the hand does dictates the shoulder. So for example, if I spread my fingers, it lifts my rib cage. If I tilt my hand, or if I externally rotate my hand as far as I can go, it affects the elbow, and then eventually it affects the shoulder, right? And so it's the same thing with the foot. If there's tightness, and what's common a lot of times is inversion. People kind of walk on the edge of their foot too much. And so as soon as that happens, it puts tension on the knee, and then that puts tension on the hips, and then you can develop all kinds of stuff. That's where that tight IT bands come from, etc. And then the opposite, sometimes you get valgus where people have their knees come in and collapse at the arch here, and then that can have it leads to pain and all kinds of dysfunction, but obviously different structures. You get more stuff going on in the groin, and it can definitely lead to lower back pain and all that kind of stuff, but reduced mobility in the hips, etc. So yeah, I know I've done a lot of talking, but point is, to put it simply, is that with the heel strike, all the nerve endings in the feet are starting to sense this, and then as you step off, things are working in unison. We take that to the springy brace position. It's recruiting the similar intelligence of the feet. So it's starting from the feet and working our way up to engage the right muscles and get the feedback that we want from the body, if that makes sense. Okay. All right, so now what we're going to do for Mark is, after doing the springy brace, he did experience a significant degree of relief just from doing that. And that was doing the exercise stuff, getting the muscles engaged, is 80 to 90% of the rehabilitation that it takes to go from feeling pain to not, in a sustainable way. With the manual techniques, I can turn off some of the muscles that are causing the imbalances, that are shortened and tight and causing compression and pulling on other structures, etc. But what Mark just did prior to is he used his own muscle force to counteract the force that is causing him discomfort. And it doesn't matter if I am the strongest person in the world as a therapist and can really get in and turn off certain muscles. There's nothing that'll ever beat the own body doing what it should be doing in the most optimal position possible. Not just because of the power that comes from all of the muscles working properly to realign, but because muscles have specific origins and insertions, so anchor points. So for example, if I flex my bicep, I'm bringing the humerus bone and my ulna bone, or sorry, not the humerus is up here, the ulna and the radius bone up this way. But if I couldn't...
Sorry, I'm thinking this camera's going to be too close. It may not actually be getting your face.
Okay.
Do you want to maybe just move it back a touch?
Move the camera back? Yeah.
Yeah, if you don't mind.
Okay.
Then you kind of see on the screen. You should be able to...
I think that'll be all right. We'll double check, but
Sorry about that.
yeah, no worries. So the muscles have the origins and insertions, meaning that they move one point closer to the other point, and it can go both ways. So the biceps as an example, if I use my biceps to bring up my forearm, so my ulna, my radius, up towards my humerus, I'm moving this bone. If this were fixed and I wasn't able to move this arm upward, if I contract my bicep, my shoulder rounds. Generally speaking, that's not a good position for your shoulder to be in. So I want to release the bicep to send the shoulder back, but I don't want to end there. I want to engage the muscles that protect the shoulder from going forward, and I want to make sure that I can use my bicep in a lengthened position that's good. So if I had issues with my shoulders, if I had tendonitis in my bicep or pain in my elbow, etc., in the anterior part of my elbow, anything up into this way where there was a dysfunction with the bicep, I don't want to ignore the bicep and not work it at all, as is a common advice with a lot of different therapy disciplines. It's actually the opposite, because pretty much all pain and tendons and muscles come from it being shortened, not lengthened. The only time that pain comes from muscles being excessively lengthened is when you're chronically under strain, like if you're working in an office and you're always this way. Yes, there's some chronic lengthening going on in those muscles, but you still want to activate them. The other time that you can get pain from lengthened muscles is from an acute strain, like you're running or something and there goes your Achilles tendon. But it's very rare to have like actual tendonitis come from any kind of issues with the lengthening. So if my bicep is shortened and I have pain here, I don't want to avoid working it at all. In fact, I want to work it more, but I have to work it in a lengthened, good position. So I'd work on getting that shoulder back. This is a different video to show, or a different, whole exercise entirely to target the biceps. I won't get into that, but in short, you want to get it in as far of an eccentric position as possible, while keeping in mind the rest of the body being in the most optimal position as possible to exert force that's good for the spine, and then get that muscle to contract under those conditions and only under those conditions. So again, that's why I can't just do that as a manual therapist. It has to be an exercise-related activity, and doing that endogenously, meaning that it comes from your own body, not from external stimulus. That always will provide the most sustaining results, and the brain, the nervous system remembers that. The body says, oh, I function way better in this position and I got myself into it. So just like we can build bad habits, we can build good habits, specific habits that train us away from our pain. Moving on, manual techniques definitely do have their place. So as established earlier, Mark has a slight pelvic twist. And one of the major muscles that are tight under these conditions is iliopsoas. Some other ones are the quadricep muscles, specifically the rectus femoris, because it goes directly from that area on the hip that I mentioned, the ASIS, down into the knee, whereas the rest of them just attach into the femur. However, it's good to address all of them, because even if the specific muscles don't cross the hip joint, they can still pull the pelvis and bring it into a bad position because the fascial connection. So if the meat of the muscle, if the dense muscle tissue gets tight and over-contracted, the fascia, both deep and superficial, is connected into that. It's often overlooked in anatomy, especially with different kinds of physical rehabilitation stuff, because we're looking specifically, that muscle's tight and that muscle crosses this joint, but we don't remember often that the fascia actually goes in this direction and that direction and so on, and some of it's deep and some of it's superficial. So we want to address all of them, but the first one I'm going to address is the iliopsoas because it's directly attached into the spine where Mark is feeling the pain. It's one of the most common muscles to cause issues when it's not working correctly. Again, when it's contracted, it's always when it's contracted. When the psoas is lengthened and working eccentrically, there's rarely any issues. So yeah. Anyway, so getting into the manual technique. So the first thing I'm going to do is just reevaluate the hips. See if I still see that twist. And again, these are just indicators. Sometimes people have what appears to be a twist, but it's just a difference in the way that their bones are formed. So there's ways to deduce that. One of the reasons why I think this is functional and not just the way Mark's pelvis is formed structurally is A, because of his movement patterns, B, because of the areas that he is experiencing pain, the way that his lumbar spine is presenting. And when we get to movement where we're looking at specifically what muscles are engaged, that's another big indicator. A lot of times, or it seems like a lot of kind of new agey therapists are kind of discrediting the idea of looking at the position of bones at all, saying it doesn't matter because there's all the, everyone's got a unique formation of their bone structure and so on. That's only partially true. You have to put the two and two together. So if I'm looking at Mark, say, bending over forward, and I know that his hip is this way, and I see only the left side of his back muscles that are contracting, where this looks like it's more of a hollow and they're not engaged, you don't see them kicking in, and there's a bit of a rotation. If I ask him to switch his hip position and then I see those muscles kick in equally on both sides of his spine, there's more to it than just his bone structure being different. So what I do is I find that point again, the ASIS. Again, the way you can do that is touching the ribs down to the hip crest, and then from there you move into the thumbs and find it that way. After enough experience, you can just kind of come, and I can see where there's a bit of the change in structure here in the hip, so I can just kind of touch it with the lateral side of my hand. I know I'm pretty darn close, and then from there I come over the crest, and the iliopsoas sits just inside of the hip crest. So I find the crest, work over it, I'm feeling his ASIS. Right now I'm feeling with this point of my hand. And so as I feel it with that point of my hand, I then turn the fingers over and enter directly into the cavity there, into the fossa of the ilium, so the space in the ilium that muscle sits. So I'd come here, and then right now the test that I'm doing is I'm feeling for it. Sometimes it's so tight that it kind of pops out, and there could be other structures that are affected too. So if I feel a softer type of tissue that's popping out, it could, and if there's any kind of tenderness there that is more superficial, it could be an appendix, it could be a intestinal issue, etc. You do go through the intestines to get to the psoas, so that's something to consider too, to kind of differentiate the type of pain that your patient may be feeling, so you can make sure that you're addressing the actual issue. So once I'm where I believe that the iliopsoas is, and it kind of goes obliquely, so the more you go down, it's more lateral, the more you go up, it's more medial, so more closer to the center of the body as you go up, closer to the outside of the body as you go down, inferior. So I'm in the area where it is. I'm not feeling it quite pop out on Mark. As I go deeper, I'm using his breath, so as he exhales, that's when I can get a little bit more depth. And if your client or your patient's not breathing well or not breathing at all, you can cue them, or you can get them to take deeper, more full breaths to really get into where you need to be. Mark's breathing quite well, so I don't need to cue him. So next thing I'm going to do here is I'm going to ask Mark, can you please lift your heel and your knee off the table just an inch? Okay, stop there. So as soon as he does that, I didn't feel the psoas before, now I feel it right under where I thought it would be. Because it's contracted, it's shortening, which makes it a little bit bigger, and I'm pretty well right in the center of the muscle. which means that's where there's going to be the most contraction, kind of the most bulk. So from here, I say, okay, well, there it is. And now that I'm on it, I can go cross fiber, meaning I'm going from left to right. The fiber direction of muscles they go in the direction between the origin and insertion. So it originates, origin is the spine, and the insertion is into his femur, which means that the fibers are going to go in this direction. When they contract, they're going to go this way. So when I'm going cross fiber, I'm going left to right because it's opposite of that, basically. And so what the cross fiber does is it allows me to feel specific points where there might be a trigger point, where there might be a little bit of an adhesion, or just general tension, and then also tissue type. So as we get closer to the tendon, it's going to feel a little different, a little denser, a little bit glidier, if that's a word, and so on. And if it's a healthy muscle tissue that's not under contraction, it's going to feel very soft and malleable, kind of squishy. Not boggy though, squishy. Boggy would mean edema, so like some kind of fluid buildup from inflammation or injury or whatever else. That's different. So anyways, so now that I'm on that spot, in order to release that muscle, there's a few things that you can do right here. If Mark was very reactive to this, I would just stay here at this point because there's no point pushing through his pain threshold to the point where his nervous system is under too much stress that it's going to cause him to contract more. But he's not giving me too much indication of being in a lot of pain right now. So the next thing I'm going to ask him to do is go ahead and drag your heel towards your butt there. So now that's approximating that muscle. So it's activating it slightly because he's raising his femur up, and it's approximating it, meaning that it's bringing those muscle fibers closer together. And the next thing I'm going to ask him to do is go ahead and bring your knee towards me. So this is a very comfortable position for me, probably not for you. But as a therapist, this is one of the best techniques because the psoas muscle contracts and lifts the femur up towards the body, but it also can internally rotate a little bit. So with him letting his knee fall out a little bit, I'm opening it into a slightly stretched position, which gives me a better position to get in there. But also we can then transition into kind of a pin and stretch where I'll get him to drop his leg. But in the meanwhile, this is just a better position for entry, and it's very comfortable for me. I can exert a lot of force without expending too much energy. So right there, obviously you can't see in the camera, and I'm not going to get a camera into his body. That wouldn't be very practical or comfortable, but I can explain what I'm feeling, and what it is I moved up that muscle, those muscle fibers, to the point where I felt a little bit more resistance, and the muscle itself kind of contracted a little bit, and it gave me a little bit of a twitch. So that tells me I'm on a spot that is worth releasing. You could call that a trigger point. And so I just kind of stay with it. As it lets go, I might add a bit more pressure. The other thing that I do here is while we're on that point of resistance, I add a little bit of rocking. So going back and forth, I don't know if the camera's going to pick up on this, but I'm basically within kind of a millimeter, just shaking his body a little bit. And the fact that I'm pressing on that muscle and the whole body is shaking is another indicator that it needs to be released. And why is that? Is because it's tight, it's locked up. When I press on that muscle, it's moving the entire body. Rather, the muscle, if it was in a healthy tone, it would move independently of the rest of the body. So I'd be able to move it, and the rest of the body wouldn't go so far with it. So this allows me to get a better indication too of when it is actually released, because as I continue to do that technique, if the point where my fingers are making contact with starts to move more freely and the rest of his body starts to move a little less, that's one of the ways I can tell that it's starting to release. You doing okay, Mark?
Yeah.
Now, there's a lot of literature out there on the psoas. It's a very important muscle. Entire books written just on this muscle specifically. Worth looking into. And so in addition to shaking back and forth, I'm kind of moving gradually up and down that spot in the muscle fibers to kind of flush out, to kind of move the blood around a little bit, kind of strip along the fiber direction, not just cross fiber, but along with the fiber direction as well. Hi, Jody. So I am starting to feel it give me a little bit more movement. Very slight, but it's coming. And so from here, I'm just going to maintain my point of contact because I still feel like there's a fair bit of tension here specifically. If that had released completely, I could move on either inferiorly or superiorly, so either towards, up towards his head or down towards his feet slightly until I find another hot spot, so to speak. But I'm just going to stay here. I'm going to take my leg off and ask you to just hold your leg there, Mark. So now he's actively holding that. So now we're asking the muscle to work while applying pressure. So we're kind of teaching it to work in a more lengthened position the same way you would do an exercise where you bring that muscle into an eccentric position, except now I'm just using my fingers to kind of pin it and force it to be a bit more extendable while it's still being worked, just to respond to that feedback. So now, Mark, go ahead and slowly let that leg slide back down to flat and kind of keep the knee slightly out as you go. Take your time. And what that does is again, that muscle has to work specifically to control the descent of his leg. If you just let it go and let it drop down flat quickly, the psoas is not going to do much to control that. So as he's controlling it and contracting it, I'm continuing to add specific pressure. So from there, I'm going to go towards his hip crest again, because at that point I was more in his abdomen. And I'm going to go to the other part of the iliopsoas. The iliopsoas is made up of two muscles. They function together. That's why they kind of refer to it as one muscle. But the iliacus is the muscle part that's actually inside the ilium more. And so I'm going to transition down to that. And think of the ilium like a bowl that sits in the muscles there. So you can kind of feel the iliac crest again and then kind of go deeper into that bowl and get into that muscle tissue. Now, you have to be more careful when you're in the abdomen because of the other structures that are there. And there is other structures in the ilium too, but they're more inferior anterior, things that you have to be worried about. Like more in the inguinal area. Right here, it's pretty much all muscle tissue, tendon and muscle tissue. So I can, as long as my patient is comfortable with the level of pressure that I'm giving, I can give a fair bit of pressure here without being too concerned about other structures that could be affected. Granted, you could pull on the fascia, pull on the skin a little bit, which can be uncomfortable. So if you feel like you're dragging too much skin with you as you go, you can kind of let that skin off, if that makes sense, and then re-enter. So I use a sheet as an example because it's more visible. If the sheet is his skin, as I transition down, you can take that with you, and then that can start to pull a little bit too much here, which also doesn't allow you to get that depth. So if you do that, you can just kind of move that skin back. And if you're entering down this way,